How are you, friends? I am presenting one more case, actually, not case, even though the topic, and definitely case as an analogy as our policy according to presentation policy. It's me, Dr. Mohammad Kazafi. You know, I am a neurosurgeon, and you are watching Dr. Mohammad Kazafi Views, and this topic is arachnoid cyst. And for analogy, one patient presented to me in front of me, the 31-year-old female, presented to the emergency department after a helmeted bicycle accident and with brief loss of consciousness. And actually, she had a past history of little depression, some depression, and non-focal headaches and the right shoulder pain. Otherwise, all examination within normal limits. On examination, neurologically patient intact with pain-related limitations of the right shoulder movement. Differential diagnosis is traumatic, definitely traumatic, and then concussion, subarachnoid hemorrhage, traumatic subdural hematoma or intraparenchymal hematoma or epidural hematoma. It was something in our mind, in my mind at that time. But definitely I did the CT scan, which I found there is a hypodense area in the left temporal area at the temporal tip, and involving the size about 5 by 5 centimeters. Then and it was a suspicion there is arachnoid cyst. Just want to confirm with the help of the MRI, and MRI suggestive for the non-enhanced T1 weighted and T2 weighted MRI of the brain demonstrate the left anterior middle fossa mass with a signal characteristic similar to those of the CSF, and the temporal lobe is displaced and the basal cistern remain patent. There is a no sign of hemorrhage. Radiographic differential diagnosis: cystic neoplasm or metastasis, or porencephalic cyst, or epidermoid cyst. But it was my differential diagnosis. But my provisional diagnosis, it is a arachnoid cyst after the CT scan, and I confirmed with the MRI. Further workup, I did the CT of the head as I mentioned before. Cranial ultrasound useful, can be done. I didn't do, but can be done for the screening infant especially. And the MRI we did with the diffusion weighted image arachnoid and cyst, and definitely the arachnoid cyst show no diffusion restrictions. MRI with contrast, arachnoid cyst show no contrast enhancement usually, and it was the case in our case. Sign phase contrast MRI to the characterized follow dynamic related to the fluid collection. CT and cysternogram is rarely necessary. Delayed or lack of contrast filling is characteristic of arachnoid cyst. ECG we did indicated only for the supratentorial arachnoid cyst if seizures or other, EEG, I am telling EEG, electroencephalogram, indicated only on that cases where the supratentorial arachnoid cyst of the seizures or other cortical dysfunctions as suspected. Neurocognition evaluation. As you know, every case has a some pathophysiology. I wanted to present this pathophysiology. Arachnoid cysts are non-neoplastic intra-arachnoid collection of the CSF-like fluid, typically arising near CSF cistern, but isolated from normal subarachnoid or intraventricular CSF flow. They are diagnosed in children and adults and account for about 1% of intracranial masses. Commonly found in the middle fossa, they also occur in interhemispheric suprasellar, posterior fossa, and spinal cistern. Primary cysts are congenital and less common. Secondary cysts may develop after trauma, meningitis, or surgery. Theories regarding the origin of the congenital arachnoid cyst include abnormal splitting of the arachnoid membrane during development. It could be. And the most arachnoid cysts are asymptomatic and stable on serial imaging. Some cysts spontaneously shrink. Signs and symptoms may develop due to the local mass effect, increased intracranial pressure, hydrocephalus, or hemorrhage into a cyst after a trauma. There is a possibility, but hypotheses regarding the cyst enlargement include CSF flow through a one-way valve, and this is the osmotic gradient and active fluid production from the cyst wall. All these are hypotheses, but still people are not certain or a final thing what we can say in front of you people. These kind of cysts, usually the arachnoid cyst, usually observation, asymptomatic or mild symptomatic cyst may be observed. Through controversial, it may be preferable to initial manage some symptoms such as the headache or the seizures medically. In asymptomatic adult, a single repeat MRI of the brain at an 8-month interval to rule out an enlarged cyst is usually sufficient. In children, observation until the adulthood with serial MRI is preferable to CT, which involves radiation exposure. Surgical management typically reserved for the symptomatic or enlarged lesion. Surgical options include endoscopic fenestration, open fenestration, burr hole drainage, shunting of the cyst. Endoscopic fenestration of the cyst wall into the adjacent CSF cistern is a minimal invasive procedure that permits visual inspection of the cyst and collection of the specimen for the pathological examination. An advantage of the endoscopic fenestration include avoiding the need of the place permanent shunt and lowers recurrence rate than a simple burr hole drainage without fenestration into the CSF cistern. 90% rate of the clinical improvement after surgery and 8% recurrence rate after the endoscopic arachnoid cyst fenestration. Cyst shunt should be considered for patient with hydrocephalus and failure of endoscopic fenestration. The endoscopic fenestration technique varies with the cyst location. In planning endoscopic cyst fenestration, considered image guidance of the optimal burr hole placement to allow access through the cyst to the adjacent CSF cisterns. Once the neuroendoscopy has been introduced into the cyst through the burr hole and the dural opening, the wall of the cyst can be grasped in to initiate the fenestration. Section of the cyst wall may be removed and care to avoid injuring blood vessels and nerves in the cistern. The fenestration may be enlarged with a small Fogarty balloon, and the cyst resection may require repeat fenestration or shunting. Avoidance and the management of the postoperative subdural hygroma or hematoma requires careful postoperative screen or coagulopathy, intraoperative hemostasis, and postoperative observation. So the symptomatic collection often require open drainage. I want to tell you, actually we did the same what I told you, that the endoscopically we tried, and patient responded very well. But seems to be but I want to talk about little how the Arachnoid cyst little more. I want to share little more knowledge regarding the Arachnoid cyst. Actually, arachnoid cysts are the collection of the cerebrospinal fluid arising from the splitting layer of the arachnoid membrane. And most arachnoid cysts occur in the anterior or middle cranial fossa or a retrocerebellar location. The etiology of most arachnoid cysts is still unclear, but they are likely formed due to abnormal splitting during the embryogenesis of the arachnoid. Intracranial arachnoid cyst may have been reported as a purely cystic tumor causing blindness as early as 15th century. So the Bright offered the first accurate description in 1831 as a serous cyst in the arachnoid, and many studies have been undertaken to better understanding arachnoid cysts since then. Most arachnoid cysts are thought to be congenital and caused by abnormal development of the meninges and the brain during fetal development. Finding of aberrant sylvian vasculature in temporal arachnoid cyst, surgical specimen reveals embryological beginnings as early as 6 to 10 weeks of gestation. Most common arachnoid cysts are detected incidental on cross-sectional neuroimaging of the brain performed for the other reason, and occasionally arachnoid cysts are identified in patients referred to the imaging due to the symptom. When they are present in the critical location and are of significant size, they can be symptomatic and require treatment. Symptoms associated with arachnoid cysts include visual loss, nausea and vomiting, macrocephaly, paralysis of the oculomotor, trochlear, abducens nerve, trigeminal neuropathy, hemifacial spasms, sensory neuronal hearing loss, facial palsy, vagus nerve palsy, vertigo, and the 8th cranial neuropathy. Depending on the cyst location, computerized tomography imaging is often enough to diagnose on arachnoid cyst when the lesion is an expected location with the appearance of the fluid-filled thin-walled cyst, and when additional information is needed, definitely magnetic resonance imaging is the imaging modality of choice for evaluating the anatomical location, size, and adjacent structures. The vast majority of cases of the arachnoid cyst need no treatment. However, mass effect associated symptoms caused by an arachnoid cyst require treatment depending on the anatomical distortion and the neurological symptoms caused. In cases where treatment is indicated, numerous surgical therapies exist, and the location often dictates the surgical approach. The etiology of formation is uncertain, but arachnoid cysts in theory are predominantly formed due to the abnormal splitting during embryogenesis of the arachnoid cyst or arachnoid layer. Therefore, histopathology demonstrates the presence of the inflammatory cells, excess of collagen, or hemosiderin. Staining suggests an inflammatory traumatic etiology, and underlying gliosis is not usually found in adjacent brain secondary to the mass effect. Underlying syndrome associated with the arachnoid cyst include Aicardi syndrome, mucopolysaccharidosis, acrocolloidal syndrome, Marfan syndrome, missense mutations, Chudley-Muller syndrome, glutaric aciduria type 1 associated with bilateral arachnoid cyst. Intracranial arachnoid cyst classification according to the anatomical location. Arachnoid cyst can be classified anatomical location. As I mentioned, it is a supratentorial, infratentorial, supratentorial or infratentorial, both. Supratentorial sylvian fissure, suprasellar area, cerebral convexity, interhemispheric space or intraventricular. Infratentorial usually cerebellopontine angle, CP angle, retrocerebellar, intraventricular, because intraventricular for supratentorial and infratentorial. Supratentorial and infratentorial combine in quadrigeminal area. A Galassi classification is another system that categorizes arachnoid cysts primarily based on location and the size. So type 1 cyst, type 2 cyst, and type 3 cyst. First of all, I will tell you type 1 cyst, which is usually small, usually asymptomatic, and located in the anterior and middle cranial fossa. Type 2 cyst located superiorly along the sylvian fissure and displays the temporal lobe. Type 2, I just want to repeat again, type 2 cyst located superiorly along the sylvian fissure and displays the temporal lobe. Type 3 cyst is large and take up the entire middle cranial fossa and displays the temporal, parietal and frontal lobe. I want to repeat the type 3, which is large and take up the entire middle cranial fossa and displaces the temporal, parietal and frontal lobes. As you know, the age range of the presentation of the arachnoid cyst is extensive and span from newborn to the older individual, though most arachnoid cysts are found in the first decade of life, and the males tends to be affected more than female, and approximately 2-to-1 ratio, but the rate varies. The prevalence is estimated at 2.6 in children, is 0.2 to 1.7 in adult. Pathophysiology I mentioned a little earlier, but I want to mention here also little. Several theories have been proposed on the pathogenesis of the arachnoid cyst. Few suggestions are like that cerebral spinal fluid flow abnormality is an underlying cause, and arachnoid cyst is hypothesized to be formed due to an irregular flow of CSF in between the embryonic meninges when the CSF pulse pressure dissect the tissue to generate the subarachnoid space, pia and arachnoid. So as these layers close abnormally and CSF is trapped. One more suggestion like that, the proposed primary agenesis of the temporal lobe, however, this is contradicted by the fact that the temporal lobe often expands in size after adequate decompression of the arachnoid cyst, implication lobar compression rather than the agenesis. One more author, his theory is like that the intrautero insult may cause the arachnoid cyst to occur, and the features suggested of an insult are the evidence of the electron microscopic feature include hemosiderin and the inflammatory cells and thickened collagen layer and the hyperplastic arachnoid cells. Location of the arachnoid cyst may also be an etiological factor. Suprasellar arachnoid cyst often instance may originate from the splitting of the arachnoid and herniation via sella, while intracellular arachnoid cyst may occur due to the herniation of the arachnoid through a defect in the diaphragm sella, and which subsequently seals off, and the intraventricular arachnoid cyst may arise from the arachnoid cells resting within the inward growth of the choroidal fissure. And additionally, most arachnoid cysts are sporadic, and significant genetic abnormality have not been identified in these cases. However, some syndromes can be associated with development of these cysts, and the etiology section for more information on syndrome associated with the arachnoid cyst. Cause of arachnoid expansion: several hypotheses have been proposed to explain the growth of the arachnoid cyst. One proposed cause is that the presence of a one-way valve through which CSF can enter from the adjacent subarachnoid space into the cyst during the systole, and which results in cyst expansion. Other possible explanations include the difference in the osmotic gradient between the CSF and the arachnoid cyst fluid, which is a driving factor for the cyst expansion, or that there is a secretion of the CSF within the arachnoid cyst. Histopathology: the arachnoid cyst consists of a thin membrane. Histologically, the wall is variable but predominantly composed of the arachnoid, and there has been found within arachnoid cyst fibrous tissue with simple epithelial lining and non-arachnoid luminal epithelia with plentiful microvilli or cilia. A wide range in the percentage of the systemic versus asystemic, a wide range in the presence of the symptomatic versus asymptomatic cysts have been reported, and this reported rate depends greatly on the population use, and the location of the arachnoid cyst is quite variable, with the clear dominance of the lesion consistently found in the middle cranial fossa and the retrocerebral location. A small number of cysts are present at the convexity and in the suprasellar region. The lowest frequency of the lesion is found in the cerebellopontine angle, intraventricular space, supracerebellar cistern, quadrigeminal cistern, ambient cistern, anterior fossa, and the brainstem. A significant variation is reported in the incidence of the less frequent arachnoid cyst location. For instance, I want to mention here there is a 0.3% only intraventricular cyst in children and no intraventricular cyst in the adults. So it means the intraventricular frequency is very, very low. Most commonly, arachnoid cysts are detected incidentally, and occasionally arachnoid cysts are identified in patients preferred for the imaging due to the symptom. Fortunately, the most common location for cysts in the middle cranial fossa and the retrocerebellar region are not associated with symptoms. Cyst is less common location, are more likely to be symptomatic. In unusual case, arachnoid cysts may cause symptoms according to the mass effect or due to the cyst rupture. Arachnoid cysts are discovered related to many different presentations, since they are usually incidental and not associated with the reason the patient is being imaged. Arachnoid cysts have been found during imaging workup for the headache, seizures, increased intracranial pressure, hydrocephalus, suspected stroke, hemiparesis, nausea and vomiting, dizziness, cranial nerve dysfunction, tinnitus, vertigo, developmental delay or regression of the development, or behavior concern, visual symptoms, and trauma. Even in patients who present with the headache, a detected arachnoid cyst is more likely on unrelated incidental finding. However, careful evaluation of each case is still required, as arachnoid cysts can be very large and cause headache and seizures in some patients. Large cysts are more likely to be symptomatic than the small cysts, and the large cysts are more likely to undergo an operation. Arachnoid cysts are rarely the cause of significant neurological symptoms such as hydrocephalus, ataxia, cranial nerve impingement. However, being the relatively common incidence and the many locations where the arachnoid cyst may occur, an extensive array of potential symptoms include the visual loss, nausea or vomiting, macrocephaly, paralysis of the oculomotor, trochlear, abduction, trigeminal neuropathy, hemifacial spasms, sensory neuronal hearing loss, facial palsy, vagus nerve palsy, vertigo, eighth cranial neuropathy, depending on the cyst location. A quadrigeminal plate cistern arachnoid cyst could compress the trochlear nerve and the quadrigeminal plate and the result in the trochlear nerve dysfunction. An arachnoid cyst impinging the optic nerve could cause a deficit in the ipsilateral visual field in the eye of origin. A cyst in the suprasellar cistern could cause bitemporal hemianopia. A cyst affect the occipital cortex and could cause homonymous hemianopia. Rarely, temporal arachnoid cysts can present with the learning difficulty and attention deficit hyperactivity disorders. Arachnoid cysts may cause atypical symptoms also. Bubble head of the doll syndrome or a rhythmic movement of the head have been reported due to the third ventricular dilatation and potential cerebellar involvement. Depression that resolve with the marsupialization of the arachnoid has also occurred in some patients. The presentation of the arachnoid cyst cause depression is quite rare but possible given the location and marked mass effect the cyst had on the brain. The rupture of the arachnoid cyst resulting in a subdural hygroma has rarely been observed. The rupture can be due to the trauma or can be spontaneous. Usually, the subdural hygroma can be followed without treatment, but the surgical intervention is occasionally required. Furthermore, the traumatic rupture of an arachnoid cyst rarely results in the hemorrhage or a subdural hematoma. Spinal arachnoid cysts are rare, occurring throughout the spinal column, but most commonly in the thoracic region. The most common symptoms are backache and the fluctuating leg weakness. Correlation with the monoparesis, radicular pain, spastic quadriparesis, neurogenic claudication, sensory disturbances, monoplasia, incontinence, pain paresthesia, and neurogenic bladder have been reported. So these are the common symptom for the spinal arachnoid cyst, which is also the rare, but and especially most commonly in the thoracic region. And the most common symptom, as you know, the backache, fluctuating leg weakness, correlation with the monoparesis, radicular pain, spastic quadriparesis, neurogenic claudication, sensory disturbances, monoplasia, incontinence, pain, paresthesia, neurological bladder have been reported, and more commonly the cyst will be located posteriorly but and also be located anteriorly. Evaluation, computerized tomography image is often enough to diagnose most fluid-filled thin-walled arachnoid cysts. When additional information needed, magnetic resonance imaging is the modality of the choice for evaluating the anatomical location, size, and adjacent structure. MRI can also help exclude differential diagnosis, and the arachnoid cyst follows cerebral spinal fluid on all pulse sequence unless impacted by a traumatic injury. And blood products are present within, although hemorrhage within a arachnoid cyst is rare. Because arachnoid cyst walls are thin, and a special pulse sequence can be employed to visualize the wall. On magnetic resonance imaging, the arachnoid cyst follows the signal intensity of the CSF on T1, T2 fast spin echo or T2 spin echo, the T2 fluid attenuated inversion recovery flare image, we can say, and the diffusion weighted image. They all are helping to diagnose this. The apparent diffusion coefficient map created from the diffusion data demonstrate the cyst has high ADC value similar to the ACF due to ACF pulsation and mild signal difference between the fluid in the arachnoid cyst and normal CSF on MRI sequence can exist. Arachnoid cysts do not enhance. An additional diagnostic study suggests that such as the CT and MRI cystoscopy can be performed to confirm a diagnosis and further evaluation an arachnoid cyst. In CT cystoscopy, a neuro-safe mnemonic iodinated contrast is injected intrathecally, and then dynamic CT imaging of the arachnoid cyst are obtained, and the amount of filling and the timing takes to fill the cyst can be utilized to guide management. Cysts that fill completely and early are considered to be the freely communicating and may not need to treat it, so the MRI cystoscopy can be performed without contrast or with contrast. Intrathecal contrast enhanced MRI cystoscopy has classically been thought to offer the advantage of demonstrating the connection of the arachnoid cyst with the surrounding CSF space. MRI non-contrast technique, constructive interface in steady state, and the fast imaging employ steady state acquisition and the 3D T2 weighted sampling perfection with implication optimized contrast with different flip angle evolution demonstrate the arachnoid cyst wall and surrounding structure. For example, the cranial nerve and the vessels. A clear demonstration of the surrounding structure can help decrease surgical morbidity. The 3D space technique helps demonstrate a connection to the CSF space, and the 3D space shows the signal loss in the area of the CSF flow, and this area of signal loss from flow highlighted the connection between the cyst and the CSF space, and similarly, the phase contrast MRI can evaluate a CSF connection to an arachnoid cyst. The flowing CSF is specifically demonstrated as a signal change on the phase contrast. However, secondary to the false positive, a connection must be confined with contrast MRI cystoscopy. Radiologists need to evaluate the brain structure for mass effect secondary to the arachnoid cyst, which ranges from the subtle mass effect on the cranial nerve to a brain herniation. A final analysis of the arachnoid cyst should only be made after obtaining an accurate history from the clinician. An accurate history will ensure that the radiological report properly reflects information about the patent cranial nerve or vascular structure that are clinically affected by the arachnoid cyst. Radiologists must also be proactive for critical located cysts and causing hydrocephalus or large cysts causing massive effect and brain herniation in this situation. The ordering clinician should be informed and the neurosurgeon should be called immediately. For the treatment, in the vast majority of cases of arachnoid cysts need to be treatment. However, in patients with the symptomatic arachnoid cyst, surgery should be considered based on the clinical factor presenting include cyst location, presence of the mass effect, impaired CSF flow dynamics, focal neurological deficit, headache, seizures, development or cognitive deficit. In case where treatment is indicated, numerous surgical therapies exist, and the surgical approach is often dictated by the location of the cyst and the involvement or the lack of involvement of the surrounding neurological structure. Surgical excision of the wall is performed with the creation of communication with the subarachnoid space when the lesion is readily amendable. Surgical fenestration or endoscopic fenestration is utilized, in which the cyst cavity is opened into the closest part of the ventricular system and the perisylvian arachnoid cyst. Endoscopic fenestration is widely used as a safe and efficient technique with the highest event-free survival compared to the microsurgical fenestration. Rarely is the placement of the cystoperitoneal shunt done, and shunt is avoided when the possible due to the complication that can arise with the long-term shunt placement. Unusual treatment are undertaken with unusual cyst locations such as percutaneous aspiration through the foramen ovale, and the surgery is almost always curative, but the recurrence have been reported in few cases. Emergency treatment could be needed when significant hydrocephalus or mass effect is present. Prognosis: in most cases, no treatment is necessary. Surgery is almost always curative when needed, but recurrence have been reported, and there have been reports for the spontaneous resolution of the arachnoid cyst, especially following a trauma. Complications from arachnoid cyst are rare but may occur depend on the cyst location and whether it causes a distortion of the adjacent anatomical structure. A ruptured arachnoid cyst can also cause subdural hygroma or subdural hematoma that need to be treated. Other complications include visual loss, nausea or vomiting, macrocephaly, paralysis of the oculomotor, trochlear, abducent nerve, trigeminal neuropathy, hemifacial spasm, sensory neuronal hearing loss, facial palsy, vagus nerve palsy, and vertigo may also occur. Patients need to inform that the most arachnoid cysts are incidental and no treatment is necessary. Only in the rare situation does the arachnoid cyst result in the need of the treatment. Few things are very important regarding this topic. The arachnoid cysts are relatively common and most are incidental. The most common location of the arachnoid cysts are in anterior and middle cranial fossa and the retrocerebellar cistern. The arachnoid cyst should have a thin wall and no enhancement. The fluid in an arachnoid should follow fluid density on CT and fluid intensity on MRI. I tried to put some light over this topic, although I think this topic is worthwhile to discuss. That's why I presented in front of you. I hope you will like it. If you like it, please subscribe, like, and share. Thank you so much. We will meet again with the new topic. See you soon.